Good afternoon and welcome to our oncology lecture series. I am Dr. Khaled Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International, and your moderator for today's lecture. It is my distinct pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our returning friends from across Latin America and the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the chat box on your screen. Please post your questions directly to the moderator. This afternoon, I have the pleasure of introducing Dr. Yuliya Linhares. Her presentation is titled Novel Treatment for Lymphoma, a focus on targeted therapies. Dr. Linhares is the Chief of Lymphoma Services at Baptist Health Miami Cancer Institute. She's a board certified in internal medicine, hematology, and medical oncology. Dr. Linhares specializes in the comprehensive treatment of lymphoma, including expertise in both autologous and allogeneic stem cell transplantation, as well as chimeric antigen receptor T-cell, or also known as CAR T-cell therapies. She also has unique experience with chemotherapy and stem cell transplantation using bloodless techniques. Dr. Linhares received her medical training at the University of North Carolina School of Medicine in Chapel Hill, North Carolina, where she graduated with distinctions. She completed a residency in internal medicine and a fellowship in hematology oncology at the University of California in Los Angeles. Prior to joining Miami Cancer Institute, Dr. Linhares treated patients in the blood and marrow transplant program at Cedars-Sinai Medical Center in Los Angeles. Dr. Linhares has extensive teaching experiences, training medical students, residents, and oncology fellows at UCLA School of Medicine. She serves as an editorial reviewer for prestigious peer-reviewed scientific publications, is widely published in numerous medical journals, and has been invited to deliver lectures at academic symposiums. Dr. Linhares is a member of the American Society of Hematology and the American Society for Blood and Marrow Transplantation. Please, let's give a warm welcome to Dr. Yuliya Linhares. Thank you so much, Dr. Linhares, for joining us this afternoon.
It's my pleasure, and I'm going to start my presentation. All right. Okay. So, all right. So hello everyone, and I'm very happy to share my knowledge of lymphomas and targeted therapies for the treatment of lymphomas. Of course, it's a very broad topic, and I know that I have a very broad audience as well. So I'm going to try to address both experienced clinicians as well as medical students in the audience. First, I would like to just come in general talk about lymphomas. I know that for a lot of trainees, medical students, residents, lymphomas are just something amorphous, lumpy, non-discrete, and hard to understand. Well, first of all, broadly, lymphomas are divided into B-cell lymphomas and T-cell lymphomas. And as you remember, probably from your basic science classes, both B cells and T cells undergo extensive transformation in their development. So this graphic on the right represents the development of B cell from the naive mature B cell to plasma cell. And as you can see, on any stage of the development, the mistakes may happen in the DNA. They're mistakes for the normal cells, but they're advantageous for the cell to become a cancer cell. So lymphomas can develop at any point of B cell maturation. And depending on the stage of B cell maturation, the resulting lymphoma would have different biology and phenotype. For example, mantle cell lymphoma develops from naive mature B cells, while diffuse large B cell lymphoma of germinal center origin develops from centroblasts. And activated B cell subtype diffuse large B cell lymphoma develops from plasmablasts. This is a very useful graphic, and I think it's always good to come back to it when you're wondering, where is this lymphoma coming from? What is its origin? In regards to T-cell lymphomas, the principle is very similar. T cells undergo extensive development from the bone marrow progenitor cell to the T cell progenitor to protein progenitor and so forth to mature T cell. The immature forms of T cells develop into precursor T cell leukemia lymphoma, otherwise known as TALL, while mature T cells develop in peripheral T cell lymphomas, and there are a lot of them. There is a whole plethora of them, but most common ones are peripheral T cell lymphoma, not otherwise specified, angioimmunoblastic T cell lymphoma, cutaneous T cell lymphomas, such as mycosis fungoides, and Sézary syndrome. A little bit on lymphoma logic, and again, this is more for the medical students. When I used to teach, my trainees loved this slide because it kind of explains the logic of B-cell lymphomas. How do we think about B-cell lymphomas? Well, it's best to think about them in regards to the degree of aggressiveness. So B-cell lymphomas range from indolent to very aggressive, and then there are intermediate types. The indolent lymphomas, the most common ones, are follicular, marginal zone, and chronic lymphocytic leukemia, while the very aggressive one is Burkitt's lymphoma. The ones in between are the aggressive diffuse large B-cell lymphoma and the mantle cell lymphoma. So why is the understanding of aggressiveness so important? Well, it's because it's important for the curability. So actually, indolent lymphomas are not very curable with conventional methods. They're cured with allogeneic transplant or now CAR T cells only, while very aggressive lymphomas are highly curable because it's easier to kill rapidly proliferating cells with cytotoxic chemotherapy. So usually when we have patients with very aggressive lymphomas, the goal of treatment is cure. The same for the patients with diffuse large B-cell lymphoma, the goal is cure. While for the patients with indolent or intermediate mantle cell lymphoma, the goal of treatment has been disease control. Of course, this is all changing now that we have new therapies on the horizon. So when we encounter patients with very aggressive lymphomas such as Burkitt's, emergent treatment is necessary because these lymphomas literally grow in front of your eyes. The same is for aggressive diffuse large B-cell lymphoma. While when we encounter patients with indolent and intermediate aggressiveness lymphomas, such as follicular or mantle cell, we really need to take time to think. Because again, the goal is to control disease without hurting the patient, to prolong patient's life without affecting its quality so much. The subtypes of lymphoma come with unique morphology and unique molecular changes. So in follicular lymphoma, follicles are preserved in the lymph node, but they are abnormal, they're expanded. That's why it's called follicular. So this is a hematoxylin essence stain of a lymph node of the patient with follicular lymphoma. And for follicular lymphoma, BCL2 translocation, B-cell lymphoma gene 2 translocation, which is translocation of chromosome 14 and 18, is very common, and BCL2 is an anti-apoptotic protein. For the mantle cell lymphoma, we get expansion of the mantle zone of the follicle, and cyclin D1 translocation is very common, which is translocation 1114, and that's what we look for in pathology. Cyclin D1 is important for cell cycle progression. We cannot have mantle cell lymphoma without cyclin D1 translocation. In diffuse large B-cell lymphoma, BCL6, BCL2, and c-MYC translocations are common, and the lymphoma itself has diffuse morphology. The lymph node architecture is not preserved. While in Burkitt's lymphomas, we see these cells that remind us of lymphocytes with very azurophilic blue cytoplasm and these little vacuoles and large nuclei. So they almost look like blasts because this is a lymphoma that's developing from very immature cells. And in Burkitt's lymphoma, we always have c-MYC translocation, which is translocation 814. c-Myc translocation. And c-Myc is a gene that's very important for cell cycle progression, proliferation, has anti-apoptotic properties. So c-Myc is really a typical and classical oncogene. So another tip to the medical students here, as you can see, we see chromosome 14 on all translocations. So why are these genes, BCL2 that's on chromosome 18, cyclin D1 that's on chromosome 11, c-Myc that's on chromosome 8, why do they like to go to chromosome 14? Well, it's because what we have on chromosome 14 is IgG, immunoglobulin G. And our B cells need to make a lot of immunoglobulins. So immunoglobulin gene has a very strong promoter. So it's very advantageous for this oncogene to translocate to chromosome 14, basically translocate to the promoter of the heavy chain of immunoglobulin. It increases the level of expression and overall oncogenicity. So I always say if you're taking your board exam or other exams and you need to recognize the translocation that's important in lymphoma, always look for 14 first and then think about the second gene. So targeted therapies, why am I so excited about this lecture? I feel like a kid in a sandbox because every day I come to work and I just have so many novel therapies to play with. And they are all very exciting and definitely more exciting than giving all the cytotoxic true chemotherapy drugs to the patient. Recently, I had a patient who had Hodgkin's lymphoma in the past, and he showed me a picture of himself getting therapy for Hodgkin's lymphoma back 5 years ago, and he looked terrible, he was bald, he lost a lot of weight. So now his lymphoma came back after traditional therapy, and I'm actually giving him targeted therapies. He's not receiving any classical chemotherapy at all, and he looks fantastic. People are telling him he looks like he doesn't have cancer. So that's why it's very important to know about these novel therapies and incorporate them into treatment. So lymphoma cells in general have various targets, right? The most classical one for the B cells is CD20. It's present on mature B cells throughout. The other target is CD19. It's also ubiquitous on B cells in all stages of development. PDL1 is a very unique target. It's a receptor on cells that tells T cells, don't eat me, I am self. The CD47 is a very interesting target. Again, it's a receptor that tells cells of immune system to not eat cancer cells, do not consume it. It blocks macrophages from eating cancer cell. And B cell receptor itself on B cell lymphomas can be a target for novel therapies. And here you are. There is a plethora of various designs of novel therapies, and we're going to go over these designs. So one of the modalities of the novel kind cancer therapy is small molecules. So again, chemotherapy, classical chemotherapy can be large and bulky, and they may not penetrate the cell membrane well or the nuclear membrane, while small molecules now can penetrate the membrane and a lot of times can penetrate inside the nucleus, which gives an advantage, and also they bind their particular targets. Instead of just damaging DNA and damaging not only the cancer cells, but also the cells elsewhere in the patient's body. Of course, everybody is aware of antibodies as a treatment modality. Antibodies are usually specific to a particular target, particular epitope on the cancer cell and induce cancer cell killing via activating immune system cells. Antibody drug conjugates are new drugs. So we have antibody that's specific to a particular target on a cancer cell or lymphoma cell that's conjugated to a chemotherapy molecule. So this way, this chemotherapy by itself may be very toxic and we may not be able to give it to the patient in a therapeutic dose. But when it's conjugated to the antibody, it goes specifically into the cancer cell and not other cells and causes cancer cell death. Other type of novel therapy is bispecific T-cell engagers, or BiTEs. So again, very interesting modality. So what we have here is usually a molecule that looks like a double-headed antibody. One side of this antibody is specific to a target on the cancer cell, while the other side of the antibody is specific to usually CD3, or a target on our own T cells. So this way, the BiTE approximates our own T cell to the lymphoma cell or other cancer cell, and potentiates the killing this way. So we're basically using our own immune system cells, our own T cells, to kill cancer cells. We're just helping them out with these BiTEs. And then, of course, the pinnacle of recent achievement against cancer are the chimeric antigen receptor T cells, or CARTs. I'm going to call them CARTs in the future. So where we have our own T cells that are engineered, that are modified to express receptors that have very strong affinity to a target on the cancer cell or on lymphoma cell. And not only they have very strong affinity for the cancer cells, but also the killing by the T cells is usually enhanced, because there is a certain signaling domains that are built in as well in the process of modifying T cells. So here we see that cancer cells are happily eliminated by our novel therapies. So in order to proceed, I'm just going to mention some abbreviations, because again, we do have medical students in our audience. Just remember, CR means complete remission, PR, partial remission, SD, stable disease, OS, overall survival, PFS, progression-free survival, EFS, event-free survival, which is usually survival without progression or without death, so a little bit broader than survival without disease progression. And RR is a relapsed refractory disease. Again, I will try to mention these, open these abbreviations when I mention them. So first, small molecule updates. Can we improve on the classical therapy for diffuse large B-cell lymphoma? Can we improve on R-CHOP? For the medical students, R-CHOP is a staple, is the #1 therapy that we've been using for over 20 years for the treatment of diffuse large B-cell lymphoma. And it includes rituximab, which is an antibody, Cytoxan, doxorubicin, vincristine, as well as prednisone. And basically, it's a default treatment for most diffuse large B-cell lymphomas. It's very effective in its own. We can say in general, it cures 60% of patients from the first try, but we could do better. So how do we do better? Well, first of all, we have to remember that not all diffuse large B-cell lymphomas are the same. So here's a slide that's called diffuse large B-cell lymphoma ABCs, because actually diffuse large B-cell lymphoma can be subclassified further into activated B-cell lymphoma or germinal center B-cell lymphoma, according to the cell of origin. So how do we do that? Well, first we have to understand that even though there's this lumpy notion of diffuse large B-cell lymphoma, part of them derive from centroblasts, and those would be the germinal center subtype diffuse large B-cell lymphoma, while others derive from plasmablasts, so later in the stage of B-cell development, and those are classified as activated B-cell diffuse large B-cell lymphomas. So as you can see, this activated B-cell diffuse large B-cell lymphomas are very close to multiple myeloma in their origin. And as you remember, multiple myeloma is not curable with conventional methods of chemotherapy. So it's reasonable to expect that patients with activated B-cell subtype diffuse large B-cell lymphoma would not do as well with conventional treatment as patients with germinal center diffuse large B-cell lymphoma. So how do we know which one is which? So actually, our pathologists help us out. They do immunohistochemistry staining, and when the lymphoma cells are CD10 positive, CD10 is a marker in the lymphoma cells, it's classified as germinal center. When it's CD10 negative on immunohistochemistry stain, then we look for BCL2 staining, and if it's positive, as well as positive for the other stain MUM1, that's considered to be activated B-cell lymphoma. If it's negative for BCL6 staining, it's a non-GCB or activated B-cell lymphoma as well. So this is the simplest algorithm. It's called HAND algorithm. Again, for medical students, it's very good to remember because it's going to be widely used in practice and widely used by pathologists to tell you, do we have ABC or GCB lymphoma based on staining? But of course, if we do gene expression profiling, the activated B-cell lymphoma versus germinal cell lymphoma cells will differ greatly. And one of the differences, for example, is that activated B-cell subtype lymphomas usually don't express BCL2, B-cell lymphoma gene 2, important for apoptosis, as much as the germinal center lymphomas. So what are the unique characteristics of this activated B-cell subtype diffuse large B-cell lymphoma? And why can we use them for targeted therapies? Well, first of all, activated B-cell subtype lymphomas are more common in older patients over 60, and in patients who have more poor performance status, so ECOG over 1. NF-kappa B pathway is important in lymphoma biology. NF-kappa B pathway is a molecular pathway that interferes with apoptotic effect of chemo. In germinal center subtype B-cell lymphomas, there is decreased activity of this pathway, and therefore they're more chemosensitive. While in activated B-cell, diffuse large B-cell lymphomas, this pathway is constitutively active, and they're more chemoresistant. So therefore, the 5-year overall survival for patients with germinal center subtype diffuse large B-cell lymphoma is 60%, while it is less than 50%, it is 35% for patients with activated B-cell subtype diffuse large B-cell lymphoma. So that's why, again, knowing the subtype is so important in clinical practice, because we're going to counsel patients on a different survival rates. Patients with activated B-cell subtype diffuse large B-cell lymphomas are more prone to central nervous system relapse. So again, in such patients, we will be thinking more about prophylaxing for relapse in CNS. And most importantly, Bruton kinase inhibitors, such as ibrutinib and acalabrutinib, are active in activated B-cell subtype diffuse large B-cell. And the reason why is because in diffuse large B-cell lymphomas of ABC subtype, Bruton kinase, which is a part of B-cell receptor signaling, is activated and is signaling to this NF-kappa B pathway, right? So making ABC lymphomas resistant to chemo. So if we inhibit BTK, Bruton kinase, we inhibit NF-kappa B pathway that's so important in ABC lymphomas, and when we can potentially get a better outcome. So is that really so? We've been trying to improve on R-CHOP for a very long time. And there was recently a very important trial, a Phoenix trial, which was a randomized phase 3 trial that compared ibrutinib and rituximab plus CHOP with R-CHOP alone in non-germinal center diffuse large B-cell lymphoma patients. So basically non-germinal center is the same as ABC diffuse large B-cell lymphoma patient. In the trial, ibrutinib 560 milligrams daily was used in combination of R-CHOP versus placebo plus R-CHOP. On the trial, 75.9% of patients had activated B-cell subtype diffuse large B-cell lymphoma. And as we see here, very unfortunately, even though we had great theories about ibrutinib, actually ibrutinib with R-CHOP combination did not improve event-free survival of all patients in the study, or activated B-cell subtype lymphoma patients if we examine them separately. Overall survival was also not better with this novel combination. So this seems to not make any sense, right? So why did this happen? Because ibrutinib can be active as a single agent in activated B-cell subtype diffuse large B-cell lymphoma. Well, there was actually a planned analysis in the study, And when they looked at patients less than 60 years old, then the data demonstrated that ibrutinib plus R-CHOP did significantly improve event-free survival, progression-free survival, and overall survival in younger patients, in patients less than 60 years old. And you can see this on the graphic A here. But what happened is this patient had slightly increased rate of serious adverse events. While when we had patients over 60 years old, ibrutinib plus R-CHOP actually worsened event-free survival, progression-free survival, and overall survival. And we can see that here. So why did that happen? Because biologically, ibrutinib should be active. Well, it turns out that there was an increased rate of severe adverse events. So toxicities with this combination in patients over 60 years old. So the toxicity rate was almost double of that of regular R-CHOP. And decreased proportion of patients over 60 could even finish and receive all 6 cycles of planned therapy. So of course, based on this data, we see that there is what we call a signal. So it looks like ibrutinib can be an additional beneficial medication for patients receiving R-CHOP who have ABC subtype diffuse large B-cell lymphoma. We just have to choose our population better. We have to choose patients who would not have increased rate of adverse events. And further investigation is warranted. Overall, I do not recommend adding ibrutinib to R-CHOP in diffuse large B-cell lymphoma patients, even in the younger ones, just because it is not an approved combination that's in the guidelines, and you may run into toxicities. So therefore, there are, of course, clinical trials, and we have a clinical trial that is furthering the study of Bruton kinase inhibitors in activated B-cell subtype diffuse large B-cell lymphoma here at Miami Cancer Institute. It is a phase 3 trial that combines acalabrutinib, which is a newer and better relative of ibrutinib with less side effects. So combining acalabrutinib with R-CHOP in patients that are less than 65 years old and have activated B-cell subtype diffuse large B-cell lymphoma. And it is a randomized trial. The trial is accruing patients who have stage 2 to 4 disease, so patients who are sicker, have higher stage disease, and higher revised international prognostic index, again, just the index of severity of their lymphoma. So what else can we do for this patient? There is a new class of drugs. Now we call them Cereblon inhibitors. Previously, we called them IMiDs, immunomodulators, and I'm sure you're all familiar with them. The oldest one is thalidomide. Then we developed lenalidomide, which is a derivative of thalidomide. Newer one, third generation is pomalidomide. Now we have avadamide, yet another generation of these drugs. So, and again, for the medical students, thalidomide actually was a sleeping medication that was widely used in Germany, and it was actually used for pregnant women. And then women started to have babies with this abnormal limbs. They're called flipper babies because they didn't have developed hands or lower extremities. So therefore, it was realized that this was a very toxic drug, and it was, of course, taken off the market as a sleeping pill. But later, when the scientists were thinking about, okay, what kind of old drug can we take that would be useful in cancer treatment, they thought of thalidomide because obviously it was toxic to the cells, causing birth defects. And thalidomide ended up to be an amazing drug for the treatment of multiple myeloma. And then subsequently, the use of thalidomide and its template generated all these newer and better Cereblon inhibitors. So what do they do? What do these molecules do? So these molecules bind to Cereblon, which actually in turn promotes degradation of transcription factors that are called islet and Icarus, so transcription factors, which in turn increases in expression of interleukin-2, which in turn stimulates T cells to attack tumors. And it also increases expression of interferon-stimulated genes which leads to apoptosis in activated B cell and germinal center B cell lymphoma cells. So potentially very useful drug in B cell lymphoma in general, and specifically in activated B cell subtype lymphoma. So why do we need novel treatments? Well, it's because historically patients whose diffuse large B-cell lymphoma was refractory to the first-line treatment, so refractory to the classical R-CHOP that we give, or another classical treatment that we give that is R-EPOCH. Traditionally, these patients do very poorly. So overall, about 26% of these patients respond to therapy, with only 7% of patients achieving complete remission. And these are patients that are relapsed or refractory to the first and second line therapy. So we really need further therapies for these patients. Their survival averaged only 6.3 months. So of course, then we think of what can we do? So we can combine the Bruton kinase inhibitor and Cereblon inhibitor in order to produce better results. And this, I call this slide a practice point, and you will see a lot of practice point slides, because this is specifically, I think this could be very useful for clinicians who treat lymphomas. So ibrutinib was used in combination with lenalidomide and rituximab for the treatment of relapsed refractory diffuse large B-cell lymphoma in a phase 1 dose escalation trial, and it was presented at ASH in 2019. It was a relatively small trial with 45 patients, again, testing combination of ibrutinib, rituximab, and various escalating doses of lenalidomide. About half of the patients on this trial had activated B-cell subtype diffuse large B-cell lymphoma. So in the whole population, overall response rate to treatment was 44% with complete remission rate of 28%. Again, remember, historically, such patients would have a complete remission rate of 7% to traditional chemo. So here we'll have 28. But it is even better for patients with activated B-cell subtype diffuse large B-cell lymphoma, with overall response to treatment of 65% and complete remission rate of 41%, which is excellent. And for patients who had relapsed disease, so again, there's a little bit of a difference, not refractory, so not the patients who never responded to chemo, but patients who responded to chemo but then relapsed. So in these patients, the overall response rate was 69% and complete remission rate of 56%, which is excellent. If we think about responses to traditional chemo, this is as good as a response to traditional chemo. The responses when produced lasted, and response duration on average was about 16 months. And median response duration was not reached in patients who achieved complete remission. So the recommended phase 2 dose was 20 milligrams, and it's now being studied. I have personal experience with this regimen, and this regimen is now built as a template at the Miami Cancer Institute, so we can use it with ease. And it's an excellent regimen for patients who have relapsed refractory disease, because imagine these are patients who already went through 1 and 2 and 3 and maybe 4 chemotherapies. And a lot of times they're what we call beat up. They're tired. A lot of times chemo prompts admissions to the hospital. They do not have quality of life. So far, this regimen, in my experience, is very well tolerated. You do need to monitor patients for neuropathy because they're getting Revlimid, which can induce neuropathy. You do need to monitor patient counts, but surprisingly, in general, patients do very well. And I had trouble with controlling my patients on this regimen because they would be going to the beach or visiting relatives and so forth. So again, something completely not typical for someone who has relapsed refractory lymphoma and very limited treatment options. This regimen is an excellent bridging therapy to patients for whom you're planning CAR T-cell treatment, especially for the patients with activated B-cell subtype lymphoma. So again, when I have a patient who failed R-CHOP, who failed ICE, I usually turn to this regimen if they have activated B-cell lymphoma. And this allows these patients to gain quality of life. A lot of times is to gain weight, to be able to exercise prior to subsequent curative therapy, which would be CAR T, or if they go into remission, would be allogeneic or autologous stem cell transplant. So there are other newer Cereblon inhibitors that I will mention briefly, such as, for example, avadamide, which potentially may be approved in combination with R-CHOP. It was studied in combination with R-CHOP for newly diagnosed diffuse large B-cell lymphoma patients, and it was studied in patients who had a higher risk disease with IPI of 3 to 5. Normally, these patients have only about 62% 3-year survival. Avadamide in combination with R-CHOP provided excellent responses with overall response rate of 88% and CR rate of 79% in this high risk subgroup of patients. 1-year progression-free survival of 80%. So again, just remember this name, avadamide. This is a drug that may gain approvals for the treatment of diffuse large B-cell lymphoma in the future, and it is in the class of Cereblon inhibitors. So now we will proceed to probably what everyone is waiting for, especially medical students, chimeric antigen receptor T-cell therapies, or CARTs. Again, what are CARTs? They're our own lymphocytes that are modified to attack tumor cells. And I will be talking about CAR T cells for lymphomas, but actually they're now being produced for all kinds of cancers, including solid malignancies, and China is actually the biggest producer of CAR T cells on the market now. So why do we need CARs? Again, because patients with refractory diffuse large B-cell lymphoma do very poorly. Remember, only 6.3 months median overall survival. So we need to do better. So what target do we choose to attack lymphomas with CAR T cells? So we choose CD19. And why is that a perfect target? So CD19 is a molecule that's expressed pretty much on all B cell lymphocytes. So on all B cells, starting with pro B cell in their development, and then all the way to late plasma blast. So it's really broadly ubiquitous to various stages of development of B cells, and therefore, of course, various subtypes of lymphomas, because they are generated on various stages of development of B cells. So again, now it doesn't matter, do we have mantle cell lymphoma or diffuse large B-cell lymphoma or CLL or marginal zone or follicular, they all have CD19, so potentially we can use a vehicle, a therapy that targets the same molecule on their surface. So we don't have to have all these different drugs for the different lymphomas. And what else is good? Well, we say, okay, if we target CD19 on lymphomas, we also kill normal B cells. That's true, but it turns out that depletion of B cells, lack of your own endogenous T cells, is actually relatively well tolerated, so we can do that. The other good thing is CD19 is not expressed on stem cells. So when we target it, we do not damage all the hematopoiesis, right? So patients are still able to produce blood while CD19 is being targeted. So how are CARTs, how are chimeric antigen receptor T cells made? First, the lymphocytes are collected from the patient via leukapheresis. So basically the machine looks a little bit like a dialysis machine, but it just takes out the lymphocytes. Then T cells are sorted out through the sorter from the apheresis product. Then the T cells are grown in the flask, basically in the lab, while being activated by various antibodies in order for them to expand. And subsequently, they are transduced through a lentiviral vector, basically a modified HIV virus. They're transduced with a construct, with a DNA construct for the modified T cell receptor. Then subsequently, they're expanded with a mix of cytokines and in co-culture with other cells that support them and stimulate them. And subsequently, they get ready for infusing into the patients. They're cleaned of the beads on which they grow and other cells. So prior to getting CAR T cells, a patient has to receive what's called lymphodepletion. So basically, we have to create a little bit of immunodeficit in the patient in order for the patient to not reject this modified T cells. So patients are lymphodepleted with fludarabine and Cytoxan, which is very, very light chemo, and it's well tolerated, can be given outpatient. And then subsequently, the modified T cells are infused into the patient, and now they are ready to fight cancer, ready to fight CD19 positive lymphoma cells. There are several clinical trials that I'm going to summarize for the treatment of diffuse large B-cell lymphoma with CAR T cells. We now have 3 CAR T cell products that are FDA approved for the treatment of diffuse large B-cell lymphoma. The first one is Yescarta. It was tested in ZUMA-1 trial. Its official name is acicaptogene silolutil. So I think it's your graduation requirement for medical schools to be able to pronounce that. So the other one is called Kymriah. It was studied in Juliet trial, and it's called tisagen lecluthil. And the other one is Lysacel or Lysacaptogene maraleucel. So again, all these products were studied on patients that were of a wide range of age, so from 20s to 70s or even 80s. All the patients had high stage diffuse large B-cell lymphoma for most. Most of the patients were very heavily pretreated, so they had 3 or more lines of therapy, and a lot of these patients were refractory. So basically, they never responded to chemo, or they were refractory to the previous line of chemotherapy. A lot of these patients on the trial had previous autologous stem cell transplant, so their disease relapsed after autologous stem cell transplant. And what do we have here in terms of complete remission? So with all the products, complete remission rates were over 40%. Again, remember, our benchmark is 7% with conventional therapy. With liso-cel or Lysacaptogene maraleucel, given a complete remission rate of 62%. Of course, remission does not last. So if we look at 6 months, about 30% of patients remained in remission with Kymriah, or 36% with Yescarta, and better so, 46% with Lysacel. So less than 50%, but still not 7%. And then the best part is that the patients who achieve complete remission, achieve CR with CAR T cells, usually stay in CR. So median duration of remission was reached with Yescarta, it was 9 months, but it was not reached in Kymriah or Lysacel trials. So the patients who achieved CR, complete remission, are very likely to maintain it. So this is excellent data, and definitely CAR T cells give hope to the patients who previously had no hope for cure. But why don't we just give these CAR T cells right and left? Why don't we give them to the patients to start with? Why don't we give them to all patients with diffuse large B-cell lymphoma? Well, it's because, of course, there are trade-offs. So there are complications that are unique to CAR T cells, and I'm going to discuss the first one is cytokine release syndrome. So imagine CAR T cells, right? So they're modified lymphocytes. So basically the way I talk about them is, imagine it's an army, and when each warrior is encountering an opponent, the warrior becomes more aggressive and actually multiplies. So that's how CAR T cells work. You infuse them. When the CAR T cell encounters its opponent, the CD19 positive lymphoma cell, it produces a lot of cytokines, and it proliferates, it expands. So cytokines, such as IL-6, can be toxic, right? They induce a lot of inflammation. So in about 5 days, it can be sooner, it can be later, cytokine release can become a problem in patients who receive CAR T cells. So cytokine release mostly in first is manifested by fever. So the patients may have fever alone, and that's when we get alerted that, okay, this patient might have cytokine release syndrome. But then it can progress, because imagine the patient is just having a huge flare, just huge boost of this IL-6 and other toxic and high quantity cytokines, and cytokine release can lead to basically shock, hypertension, heart damage, pulmonary damage, neurologic complications, liver failure, and so forth. So luckily, now we know that IL-6 interleukin 6 is a central player in the development of cytokine release syndrome. And there is an antibody called tocilizumab that we have on hand available for CAR T cell patients. So when the CAR T cell patients develop higher grade cytokine release, not just fever, but we start seeing that their blood pressure is dropping, that they are getting organ damage, we give them tocilizumab, and usually it can basically turn off this process very rapidly. In order to monitor cytokine release, we can measure other markers of inflammation in the patient, such as CRP, C-reactive protein, or ferritin. Usually they start going up as the patient is developing cytokine release, and the higher they go up, the higher is the risk of this process being more severe. So the second unique toxicity of CAR T cells is neurotoxicity, or immunotherapy-induced neurotoxicity. So again, here's the timeline of CAR T cells. Patients receive lymphodepletion, patient receives CAR T cell infusion, and then in 1 to 10 days, usually it's like neurotoxicity happens a little bit later than the cytokine release syndrome. Patient may develop all kinds of neurologic manifestations. They can range from some confusion, they may not be able to recognize their relatives or doctors, to tremors, inability to write their name, hallucinations, and as far as global encephalopathy and cerebral edema and even coma. So again, pretty serious adverse event, and it happens in most patients who receive CAR T cells that are now approved, but we can treat it. So the treatment for neurotoxicity is dexamethasone. So again, the moment we notice that the patient may be developing neurotoxicity, we start them on dexamethasone. Again, not tocilizumab, that's for cytokine release, but dexamethasone. And again, in most cases, this is reversible and not fatal. Nevertheless, cytokine release and neurotoxicity are both very serious adverse reactions. A lot of patients need hospitalization for their management, and therefore this makes CAR T cell treatment very expensive. Not only the base cost is about 400,000 doses for a dose of CAR T cell, but then the care for these patients, ICU stays due to cytokine release, neurotoxicity, is very extensive and very expensive. So again, this is our 3rd to 4th line treatment for patients who can't achieve remission and go for transplant. We do have CAR T cell clinical trials here at Miami Cancer Institute, Baptist Hospitals, and the clinical trial that we have is a safety trial of lymphocytogen miraleucel, which is liso-cel for relapsed and refractory B-cell non-Hodgkin's lymphomas, including diffuse large B-cell transformed from indolent lymphoma, primary mediastinal B-cell lymphoma, or high-grade follicular lymphoma. And this is a trial for patients with relapsed or refractory disease after at least 2 systemic therapies. We have treated multiple patients with CAR T cells, and this is a unique trial because in this trial, we give CAR T cells on the outpatient basis, and we actually can keep the patient outpatient. We don't admit them for observation. So far, about half of our patients were able to stay outpatient because actually, like the lymphocytogen miraleucel, CAR T cells are unique because they have very low rate of severe cytokine release and neurotoxicity because of their unique formulation. In lymphocytogen miraleucel, equal doses of CD4 and CD8 cells are used in the CAR T cell product. So do we have CAR T cells for other subtypes of lymphoma? So I'm very happy to say that yes, recently Tecartus or brexacaptogene autoleucel was approved for the treatment of relapsed refractory mantle cell lymphoma. And I'm sure that clinicians here have dealt with patients with relapsed refractory mantle cell lymphoma, especially the ones who carry P53 mutation. And previously, these were patients who had no hope or no treatment options. And their median overall survival used to be 5.8 months after the failure of last therapy. But recently there was a trial, Zuma 2 study, that demonstrated that in relapsed refractory mantle cell lymphomas who experience 1 to 5 lines of therapy, including Bruton kinase inhibitors, and in patients with high stage disease, overall response to CAR T cells is 86% with complete remission rate of 57%. Again, these are remarkable results. We do not have Tecartus available yet at Miami Cancer Institute, but it is available at the University of Miami. And I have referred patients for this treatment. It was really wonderful to see patients who had disease that I was not able to treat or cure with anything. It was wonderful to see this patient go in complete remission and survive their otherwise previously fatal disease. So the duration of response with this treatment is excellent. 12 months, 83% of patients remain in remission, and 86% of patients are alive 12 months after receiving CAR T cells for mantle cell lymphoma, and about 80% of them do experience cytokine release syndrome. But in the trial, there were no deaths due to cytokine release or neurotoxicity. So what about other subtypes of lymphoma? Of course, CAR T cells are now being investigated for a wide range of lymphomas, including CLL, marginal zone, primary mediastinal. But I just give an example here for the follicular lymphoma patients. So previously, when I met follicular lymphoma patients, I had to tell them that their disease would have a chronic course and it would not be curable unless we utilize allogeneic stem cell transplant. But it is not so anymore. And I think that CAR T cells will be approved in the near future for patients with follicular lymphoma. So here's an example of a small trial of 8 patients who received CAR T cells, CD19 targeted CAR T cells for follicular lymphoma. Complete remission rate 88%, very high, even higher than that for patients with diffuse large B-cell lymphoma. And patients who achieved remission remained in remission for the median at the median follow-up of 24 months, 2 years. Again, they experienced cytokine release and neurotoxicity, but there were no severe adverse events. So the adverse events were only mild to moderate. So what if we have a lymphoma patient that is not eligible for CAR T cell treatment or autologous stem cell transplant? What are our other treatment options? Well, there are many, and one of them is an antibody targeting CD19. It's called tafasitamab. Again, it's a recently improved drug, and I'm going to share some clinical trial information on tafasitamab. Again, this is a practice point because this is a regimen that's approved and we are using it successfully at Miami Cancer Institute. We have a built electronic order set because it's a little bit cumbersome to order, but it's a regimen that combines tafasitamab with lenalidomide for relapsed refractory diffuse large B-cell lymphoma. And this regimen was studied in a phase 2 L-MIND trial. So in this trial, 80 patients who were not eligible for transplant with relapsed refractory diffuse large B-cell lymphoma were treated with this antibody, tafasitamab, lenalidomide combination with excellent results. Overall response rate 60%, complete response rate 43%. And again, as we remember, our benchmark from previous conventional therapies is only 7% complete response rate. Duration of response, excellent, 21.7 months. Excellent median progression-free survival of 12 months, and median overall survival was not reached with this regimen with a median follow-up of 19.6 months. I currently have a patient on this regimen. He's an elderly person, he's over 70, he had congestive heart failure with low EF fraction, so the patient would not be a candidate for cytotoxic therapies. And he is doing fantastically well on this regimen. He looks like he does not have lymphoma. He went into remission quickly and he is enjoying his life. So this is an excellent regimen to utilize in older patients with relapsed refractory diffuse large B-cell lymphoma. But we have to remember that tafasitamab targets CD19. And CD19 is also a target for CAR T cells. So we normally don't want to give CD19 targeted therapies prior to CAR T cells because we do not want to deplete this target, right? We don't want cancer to adapt and start hiding this target prior to giving them the curative treatment of CAR T cells. And more. So there are actually more options for these patients. And the next option would be antibody drug conjugates. As I mentioned before, the novel modality of therapy where we have antibodies that are conjugated to chemo molecules that can specifically attack lymphoma cells through specific markers. So the next antibody drug conjugate I would like to talk about is called loncastuximab. So it's a new kid on the block, and it's a CD19 specific immunoglobulin that's conjugated through a linker to the molecule of tesirine. So loncastuximab is an antibody-bound tesirine. So tesirine is otherwise very toxic chemotherapy molecule that you would not be able to give to the patient without killing the patient. But this way we just target it to the cancer cell and we are able to deliver it efficiently without significant side effects. So loncastuximab was tested in a phase 1 trial in patients with relapsed refractory B-cell non-Hodgkin's lymphomas. It is administered intravenously every 3 weeks. There are some toxicities such as lower blood counts, liver test abnormalities, fatigue, shortness of breath. But again, remember, so these are mostly what we call biochemical toxicities or lab toxicities, right? And maybe some fatigue. So patients who have very refractory disease are not getting hair loss, they're not getting nausea, vomiting, diarrhea. So basically, they're maintaining their quality of life with this treatment. So overall response with the highest dose was 59%, which is excellent in this population, and a complete response rate was 60.6%, 40.6%, again, 40.6% in patients with relapsed refractory diffuse large B-cell lymphoma. Again, way better than 7% previously. Median progression-free survival was 5.5 months. So it looks like patients responded, but the response didn't last for that long. Therefore, of course, it makes sense to investigate this drug loncastuximab in other combinations. So at Miami Cancer Institute, we do have 2 clinical trials of loncastuximab. The first one is a phase 3 trial that combines loncastuximab with rituximab versus a traditional R-GemOx regimen in patients with relapsed refractory diffuse large B-cell lymphoma. And the second trial that we have is a trial of loncastuximab with ibrutinib for the treatment of diffuse large B-cell or mantle cell lymphoma in relapsed refractory setting. So next antibody drug conjugate I would like to talk about is called polatuzumab vedotin. So polatuzumab vedotin targets yet another molecule on lymphoma cells. It targets CD79B. And polatuzumab is an antibody conjugated to this molecule that's called MMA, monomethyl auristatin. Again, MMA in itself is very toxic. And it is not a type of medication that could be given to patients safely. But when it's bound to the antibody, it's targeted directly to the cancer cells and does not have that much of a toxicity. MMA is a microtubule inhibitor. So again, here I would like to note that polatuzumab targets CD79B, not CD19, which makes us think that this therapy would potentially be a very good bridge for the patients who are awaiting CAR T cell therapy. So if we have to try something for patients awaiting CAR Ts, I usually choose polatuzumab in combination with rituximab plus minus bendamustine. So here is a clinical trial data of polatuzumab vedotin in combination with bendamustine and rituximab in relapsed or refractory diffuse large B-cell lymphoma. Again, the combination produced excellent responses. 40% of patients receiving combination treatment with polatuzumab went into remission versus 17% of patients who received classical bendamustine rituximab therapy. Most importantly, overall survival was significantly improved in patients who received polatuzumab bendamustine rituximab combination, and the risk of death was reduced by 58%. The patients had a longer median overall survival of 12 months versus only 4.7 months in the patients receiving bendamustine rituximab alone. The main toxicity of this regimen is neuropathy. The patients have to be followed very closely for neuropathy, as they can develop sensory and motor neuropathy, both which can significantly decrease their performance status. Especially given the fact that this patient usually already had been exposed to other agents causing neuropathy, such as vincristine in the previous regimens, or possibly Revlimid or others. Polatuzumab bendamustine rituximab regimen is now approved for the third-line treatment of diffuse large B-cell lymphoma. Again, praxis point, I do have to say that this is probably the most favorite second and third line regimen for the treatment of diffuse large B-cell lymphoma at our institution, because of course it's not FDA approved for the second line, but usually we are able to get insurance approvals. Why do we love it? Well, first of all, it's an outpatient regimen, so patients don't have to be admitted, and they only receive treatment for 2 days, day 1 and day 2, every 3 weeks, and they are outpatient, versus classical chemo regimens that we would use, such as, for example, ICE or ESHAP, that make patients pretty sick. Patients have to be admitted. Patients develop bad cytopenias, neutropenias. So in general, our patients have been tolerating this regimen very well. They're able to remain outpatient. Usually we do give Neulasta for white cell support with this regimen. And normally I do not see very significant cytopenias. I see occasional neutropenia, but again, nothing that warrants admission with this regimen. It's an excellent bridge regimen, bridge to transplant, bridge to CAR T cells, because again, on this regimen, patients can thrive. They can regain their appetite, they can regain their energy in order to be prepared for their next line curative treatment. This regimen can be used in patients who are not candidates for curative treatments either. It's pretty well tolerated, and as we see, gives them pretty good median overall survival. So it's already after 5. Can I continue, or do I have a little bit of time?
We have a few more minutes. We had scheduled everybody for only 1 hour, but absolutely, if you need to go.
So I will keep going. Again, there is a lot to cover, and as you can tell, I'm as excited as you are about all these new treatments. So the next interesting type of molecule that I would like to mention for the treatment of lymphomas is a BiTE. So bispecific T-cell engager. BiTEs are these double-headed antibodies that on one side engage the cancer cell in accordance to its target. So in this case, it's CD20 with the T cells, and usually they target CD3 on the T cells. So they physically approximate T cells to the lymphoma cells, inducing T cell cytotoxicity, T cell killing of the target cells. And again, BiTEs are being developed for all kinds of cancers, but here we're going to talk about mosunetuzumab. So mosunetuzumab is a novel BiTE towards CD20 on one end and CD3 on the other end. Again, this is a therapy that is used for patients with relapsed refractory diffuse large B-cell lymphoma, as well as other lymphomas. Of note, and very important, in the clinical trials for mosunetuzumab, 30% of patients who were enrolled failed CAR T-cell therapy. So they failed the definitive, potentially curative last resort therapy already, right? And so right where you think there is no hope, there is actually hope, because it turns out that about 39% of patients who failed previous CAR treatment responded to mosunetuzumab, and 22% of patients achieved complete remission. Again, you may say, okay, well, this is below 50%. These results are great. these results are not great, but I think these results are actually fantastic given the fact that these patients would not have any other option, would not have any other hope. And this was a response to single agent mosunetuzumab. So in patients, in general, follicular lymphoma patients, their overall response rate to this therapy was 62% with CR rate of 43%. And in diffuse large B-cell patients, CR rate was about 19%. When patients responded, responses tended to be durable, with 17 of 24 patients treated remaining in complete remission up to 16 months, which is really interesting and excellent. And what is the toxicity of this treatment? So as we can imagine, here we have this antibody engaging T cell to lymphoma cells. So of course, T cells, even though they're not modified, these are our own T cells, will start releasing cytokines in order to kill the lymphoma cells and proliferate. And one of the adverse events of interest in the mosunetuzumab trials is cytokine release, but in general, it's usually mild and it is not fatal. So we are about to open mosunetuzumab clinical trials at Miami Cancer Institute. I really like these trials because one of them gives an option of mosunetuzumab in combination with rituximab for patients who are not chemotherapy candidates. So for example, if you have a patient who is, let's say, 81, 82, has congestive heart failure, cannot get conventional chemo, mosunetuzumab with rituximab combination, so chemo-free treatment, could be an excellent option. And mosunetuzumab is also in clinical trials for consolidation. So for example, we have a patient with activated B-cell subtype, diffuse large B-cell lymphoma. We know that they're high risk. We know that their 5-year overall survival, progression-free survival will be about 35%, right? So how can we improve it? So there are trials of mosunetuzumab maintenance after completion of initial chemotherapy, such as R-CHOP, and in hopes that mosunetuzumab maintenance can improve progression-free and overall survival of such patients. So now we will talk about another target that is a very exciting target. I would say I'm most excited about this one. It is CD47, and it is a molecule on the tumor cells that tells macrophages, do not eat me. It literally is called do not eat me target. So our macrophages are quite capable of attacking tumor cells, but they normally encounter CD47 on the cells, which blocks this macrophage activation. So the receptor on macrophages that engages with the CD47 is called SIRP alpha. Normally this interaction does not lead to tumor cell killing. And again, tumor cells are very cunning. So what they do is not only they express CD47 just as many other cells in our body, but they actually tend to overexpress it. So they would be covered with CD47 to prevent them from being eaten by the macrophages. So now we developed antibodies to CD47, and one of them is TTI-621. So antibody to CD47 blocks the CD47 on tumor cells. Therefore, macrophage is free to engage. The SIRP alpha is free. It is not signaling for macrophage to stop, and it can engage with the tumor cell and kill the tumor cell. So TTI-621 is a novel therapy, again, new kid on the block. It's a human immunoglobulin with a binding domain that's specific to CD47, and it blocks the CD47 do not eat me signal. But not only that, when this molecule, when this modified antibody binds to tumor cells, it also engages, it actually stimulates immune system to kill cancer cell through this human IgG domain. So here is an example of a phase 1 trial of TT-621 in cutaneous and peripheral T-cell lymphoma. And again, this is for our medical students. Cutaneous T-cell lymphoma, the most common subtype, is mycosis fungoides. It can be a terrible disease. It can range from very indolent presentation with occasional patches of rash to very extensive, where patients may have itchy, pruritic, tormenting patches of rash all over their body, or that can be raised, they're called plaques, or it can even go into tumor stage where the whole patient's body can be covered by tumors, and that's highly and rapidly fatal. Mycosis fungoides can also evolve into what's called Sézary syndrome, where these T cells, the cancerous T cells, are present throughout in the blood, infiltrate skin, causing what's called erythroderma. So the whole patient's body is red. Usually also patients are miserable. They have a lot of itching, a lot of pruritus, and Sézary syndrome is very hard to treat. We have very few treatment options. So in this clinical trial, 40 patients with T-cell lymphomas were treated with monotherapy of TTI-621, and the overall response rate was 17% in mycosis. And again, it's very refractory patients who already had and exhausted all other treatments. 20% response rate in Sézary syndrome and 18% response rate in other peripheral T-cell lymphomas. One Sézary syndrome patient achieved complete remission after 48 weeks of treatment, so kind of a late response. And the adverse events were some infusion reactions and thrombocytopenia. So basically, very well tolerated therapy. And here we can see among these 40 patients, there are a lot of patients who had stable disease or partial responses or complete remission, and these responses are still ongoing. So again, we have a low toxicity option for patients who otherwise had no options at all. So this compound, TTI-621, is also being investigated in the form of intralesional injections. So basically, it's being injected into mycosis fungoides tumors, and then the response is assessed. And very curiously, when it is injected, not only they observed that the particular isolated lesions responded, but actual lesions that were not injected in the same patient also responded. So in this case, TTI-621 was injected into calf, so into a leg lesion, but the mycosis lesions on patient's abdomen resolved. So basically, it looks like it penetrates into the bloodstream and is active in the rest of the body as well, enabling our own immune system to kill cancer cells. So among all the treated patients, 91% of patients had decreased lesion severity score, and 41% of patients had reduction in severity of scores by over 50%. So significant clinical benefit to this compound. And most importantly, we have to remember that CD47 is a universal target. It's present not just on T cell, B cell lymphoma cells, multiple cancers. And if we are able to suppress this, then we can enable macrophages to fight multiple types of cancers. So these do not eat me signal inhibitors are being developed for the treatment of multiple tumors, including, for example, acute myeloid leukemia, and including the cancers that are very chemo resistant. So cancers for which we cannot use traditional chemotherapy, such as anthracycline, Cytoxan, successfully, because this treatment is independent of the traditional chemotherapy resistance mechanism. And so I do have a little bit on targeted therapies in Hodgkin's lymphoma, but I do not want to overstay my welcome. So please let me know.
Dr. Linhares, this presentation is absolutely phenomenal. I wish we could have at least a week with you, 24 hours, so we could actually learn directly from you. You were absolutely on target when you said that everybody is excited about CAR T-cell, and I promise you, you have gotten the attention of every single student and every single oncologist that is today with us. Unfortunately, we are on top of the hour already. We do have, before we leave, just as a courtesy, we have a couple of questions. See if we can briefly read them and get some answers to these good doctors that have been patient with us. It says, good afternoon from Dr. Nunez in the Dominican Republic. When patients with lymphoma diagnosis could get vaccination against COVID-19, contraindications to get any contraindications that we know of that they can get the vaccine? Any specific type of vaccines that are one better than the other in relation
Yes.
to pathologies?
So this is an excellent question, and I'm very happy that it's very relevant. And uh, actually, this was a question to me as well, because when we started giving vaccine 2 months ago, I didn't know. So our algorithm was to give the vaccine, and at that time we had Moderna and we had Pfizer, so we had RNA vaccines. So we gave these vaccines to all our lymphoma patients, whether they finished therapy or whether they were currently on chemotherapy such as R-CHOP, bendamustine, rituximab. So we gave it to everyone. But I decided to follow up and measure whether our patients actually developed antibody response to the vaccine. And you have to remember, when you're trying to assess antibody response to vaccine, you can't use regular COVID antibody test. You have to use a special test that specifically detects antibody-induced, the vaccine-induced antibody. So here the name of the test is COVID-19 spike protein semi-quantitative antibody. So that's the test that will detect antibody from the vaccine. If you order regular COVID antibody test, it only detects antibody for COVID infection, if someone survived COVID, right? And so basically I vaccinated many patients. Among my patients, we did not have a single patient with an adverse reaction that was immediate. I had one patient who is on Gleevec for chronic myeloid leukemia who developed severe muscle aches and even had to be admitted. And I can't really find any other reason other than the COVID vaccine. So I think maybe there was some kind of immune reaction. My other colleague had one patient who developed severe thrombocytopenia, severe low platelets from RNA vaccine. But otherwise, hundreds of patients vaccinated, they were just fine. Basically, some arm soreness and maybe some fatigue on the second day after the RNA vaccine. But most importantly, I am measuring antibodies for vaccine, and I have not seen a single patient who developed antibodies to RNA vaccines, the single patient who was on chemo or getting rituximab. So basically, I talked to my friend, his name is Otto Yang. He's a world famous COVID expert from UCLA. And he published a New England Journal of Medicine article on COVID antibody responses. So he told me that most likely COVID vaccines will not be effective in patients who did not recover their B cells after the lymphoma treatments. So if you have a patient who received rituximab, you probably have to monitor for B cell recovery. So I would say look at total lymphocyte count and maybe do flow cytometry and see if B cells are in the normal range. And if they are, then I would say, again, I don't know, then most likely these vaccines would be efficacious. So otherwise, they have not been efficacious at all for my lymphoma patients on active treatment or shortly post completion of treatment. So basically, if we give vaccine to such patients, we would be providing false security. So I stopped vaccinating my lymphoma patients who are receiving chemo or targeted therapies because their B cells are just not functional. Again, because now we have another spike of COVID here because all these vaccinated patients think that they're okay and they wouldn't get sick, but they're getting sick. Mm-hmm. And I'm sorry about the type of vaccine. Again, my friend, the expert friend, he told me that it shouldn't matter. He told me that RNA vaccines are most effective. So if RNA vaccine didn't work, it's very unlikely that other like DNA or protein vaccine would work.
Mm-hmm. And now, obviously, those are for patients that are actively receiving treatment. However, exactly. Those that are already in remission, would they be okay receiving the vaccination?
Yeah, for patients that are in remission and let's say their B cells are recovered. So let's say they're 6 months post completion of rituximab, but I can't give you exact number, right? The B cell recovery will be different in different people. So they're completely fine to receive vaccine. The question is we don't have data on how well they will respond. So right now I only have data for patients who are on treatment who received vaccine or recently post-treatment and they did not form antibody. I don't know, I don't really know about the effects. So I would say give the vaccine, but then if you have an opportunity to measure antibodies to not provide false security to the patient.
Of course. From Costa Rica, Dr. Esteban is asking, which of these novel therapies are available for refractory classic Hodgkin's lymphoma, and what is your experience with using them?
Okay, so excellent question. I love it because that's my next slide. So I'm just going to go there. I'm going to send this presentation so everybody can have it available. But I'll just go to my favorite one, of course, for relapsed refractory Hodgkin's lymphoma. My favorite regimen is the following. It's this slide. It's a combination of brentuximab vedotin, which is a CD30 targeted antibody drug conjugate, with nivolumab, which is a PD-1 inhibitor, right? So it disinhibits our immune system in order to fight cancer. Excellent combination. First of all, completely chemo-free, right? So that's the patient that I was talking about who looked horrible initially when he was treated for Hodgkin's. Now his disease came back. He walked into me looking like a skeleton with a lymphoma everywhere. And now he's basically full-time working. Only after 2 cycles, 2 doses of this treatment, he's working full-time, and he's upset because no one thinks he has cancer and is giving him a special treatment. So excellent regimen, nivolumab, brentuximab, not only because it provides excellent overall response rate, 85%, CR rate 67%, but it was studied as a bridge to autologous stem cell transplant. So when these patients get transplant, they have amazing survival. So 2-year progression-free survival for the ones who undergo transplant with this regimen prior to 91%. So this is the best known, and this is definitely our go-to regimen. Of course, I understand that it would not be available in all countries. This is very expensive. So alternative regimen would be bendamustine in combination with Etcetris. Also very high response rates in some studies, almost 100% overall response rates. People go to transplant, and here's a little table actually, I incorporated it here. So with that approach, brentuximab vedotin with bendamustine and then transplant, 67% progression-free survival, which is also excellent. But that's for intention to treat analysis. So some patients didn't even get all the doses. So it's actually even better than this. So I would say that's another good alternative regimen. So in general, we try to avoid this ICE, ESHAP, and so forth. And that's a table showing it, because with ICE, ESHAP, traditional salvage regimens in general, after transplant, the 5-year, for example, 5-year follow-up CR rate 17%. Well, with our chemo-free regimen, 3-year progression-free survival is 75% for all patients. And like I said, it's 93% for the ones that undergo transplant. So definitely brentuximab, nivolumab is excellent. And if we have to do single agent, it would be nivolumab as a single agent. It's been shown to be better than brentuximab single agent for relapsed refractory patients.
Excellent. What do you think about the role of or use of consolidative proton therapy after schemes of chemotherapy in patients with Hodgkin's lymphoma? So the use of proton in combination with chemotherapy and Hodgkin's lymphoma.
So I think that's a very interesting question. I actually cannot give you an educated answer. So for low stage Hodgkin's, that is in a good radiation field, right? Not in the mediastinum for a woman, because we're trying to avoid radiation there, right? But low stage disease, we do use combination of chemo and then radiation, but I haven't used proton therapy. And I will tell you, we have trouble with using proton therapy because insurances are refusing to pay for it. So even for patients, let's say, who have marginal zone lymphoma or follicular, just one lesion, and the only modality I'm using is radiation. I'm not even using chemo, right? So we're going for cure, and let's say we have a sensitive site, such as salivary gland. So we definitely don't want to use more toxic radiation. Even in those cases, I've been getting a lot of insurance refusals to pay for proton therapy. So I can't really tell, I don't know how it would work in the setting of Hodgkin's. So in general, so we have a clinical trial for Hodgkin's, and the trial is Adcetris, nivolumab, doxorubicin, and dacarbazine. So basically 2 targeted therapies and 2 classical therapies. And this trial is for patients with all stages. And on this trial, patients do not get radiation therapy. So I actually have been putting patients on the trial, and I've been avoiding radiation therapy because on the trial, excellent responses, everybody goes into complete remission after 2 cycles. So it's likely to become a new standard of care.
Dr. Linhares, just like I told you, we can have you here for hours on end, but unfortunately, we have reached past the top of the hour. And I want to thank you on behalf of Baptist Health International and the entire system for accepting our invitation for today's presentation, and to all of the participants that attended today your lecture. We want to thank you.
Thank you so much, and I'll say in Spanish, muchas gracias, y fue mi placer. Entonces, siempre estoy muy feliz de ayudar a mis compañeros en los otros países. Entonces, voy a compartir mi correo electrónico y también esta presentación. Y cualquier cosa, siempre me pueden escribir.
Gracias, Dr. Linhares. If you have any additional questions to Dr. Linhares' presentation, please feel free to email us at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will make sure to pass those questions along to Dr. Linhares for her answers, and we will forward those to you. We look forward to seeing you at our next oncology lecture series, which is scheduled for July 14th, 2021. Thank you again. Stay safe, get vaccinated, and let's get back to life. Thank you, Dr. Linhares. Have a wonderful weekend.
Goodbye.
Thank you.